Hello, I'm Dr. Brian Silverstein, Chief Population Health Officer at Innovaccer, and so excited for our podcast today. I think everyone's acutely aware of all of the different myriad of issues that are going on in healthcare. And what we want to do is talk about people that are making a difference and doing things they're passionate about and also having positive impacts of change. So, super excited for today's podcast. We've got Darren Malinoski. And Darren has a particularly interesting background because, not to typecast, but all of us know that within the physician community, you've got people that are in medicine and people that are in surgery. And then within surgery, there's subspecialties there as well. And Darren happens to be, a trauma surgeon. And so those are the people that really huge adrenaline junkies, they're into it, highly skilled, and usually people that are really focused on something that's very immediate and able to get amazing results. And what's really interesting is and I've had a chance to talk to Darren, is learning about his career and how he's taken his training and his expertise in clinical medicine and in surgery and been able to use that for transformation purposes. So it's quite a journey. And so I'm super excited for this. And, let's dive right in. Darren, I know that obviously you've got incredible clinical background and training, but you're now in this administrative chief transformation role. So share with me a little bit about how did you migrate from, being one of those adrenaline junkie trauma surgeons to your current position?
Well, thanks, Brian. Thanks for having me. It's a great opportunity. And I'm happy to share a bit about my journey and some of the work that I get to do. And you're right. Being a trauma surgeon who's gotten involved in value-based care and clinical transformation is not common. And I think I began to realize that my journey through medicine wasn't going to be typical pretty early on after training. So where I did my fellowship at LA County USC, there was the practice where the fellows would all give a lecture on a topic, even if 6 lectures a year, and sometimes that lecture would turn into a protocol or some other work to do. And I wound up giving a lecture on preventing center line infections by creating a line cart of the right supplies and an education program and a protocol for assessing the need for that central line every day. Because if you take it out sooner, then they won't get as infected as often. And I gave the presentation on what I had seen others do around the country, and then I was asked to implement that during my fellowship for our large academic health center, trauma center, and worked with a performance improvement consultant who advised me, gave me a lot of guidance on how to do administrative work, policy, educational materials, and then go ahead and tell that story and get people to adopt the new path and then hopefully decrease your infections. And so the act of working on that educational program and that clinical pilot to achieve some results really got me hooked pretty early in performance improvement, in change management, and even in research, because if you affect change and you can write about it and disseminate that story, that has some academic credibility and helps you in that part of your career as well. And so early on, I kind of realized that optimizing a policy and getting people to change their behavior was something that I thought was engaging and rewarding. And I began doing that pretty early on in parallel with my clinical work.
That's fantastic. And it's interesting, that notion of behavior change, because that can be applied at multiple levels. It could be applied from a clinical setting. You want patients to do something differently. It can be applied with our colleagues when we want to have different practices and protocols. It could be applied on a system level. So it's really that multi-level thinking. And so one of the areas that I know that you have a particular passion around is around organ donation. And this is something that, obviously in our country is a big challenge. There aren't enough organs that are available. And certainly, especially when you think about solid organ transplant, kidney transplant makes a huge difference in patients. I know that you've been, very passionate in the space. So would love to hear a little bit more about what you've done.
Yeah, thanks. It's part of my background doing the fellowship where I did and learning some of the performance improvement work that I did. Another unique element was the fact that in that facility, all the trauma fellows would take care of any potential organ donor in the hospital. And what that meant was whether someone had a stroke or a brain tumor or traumatic brain injury, which are the patients I often took care of, if the teams thought they were potentially brain dead and needed to be declared as such, and then potentially facilitate organ donation if that's what the patient and family had desired. That was something that the culture was our team took care of those patients and facilitated that work with the organ procurement organization, and then got to find out what happened to those organs that got placed and who got them and how they were doing. That was really gratifying and rewarding. One, the medicine and the science was hard. The family dynamics were also a challenge, was the second part. And the third part was you realize this common good. You wound up helping somebody you never even met by helping facilitate organ donation for that patient at the bedside. And so that's what I was just indoctrinated to understand and learn and practice. And so my first job, the hospital I went to work for, did not have an established organ donor council. They didn't have a lot of relationships with the organ procurement organization. And their work around preserving that option of organ donation for patients and families who choose it, and then the recipients who need those organs, really was limited. And so I happened to walk into the first meeting of that council, and people were talking about what they had learned and what they needed to do to take some steps forward. And I worked somewhere for a year where I really had learned all of that and was able to share, well, here's how we did it this way, and this would work well. And so I wound up being asked to be the chair of the Organ Donor Council my first year out of training, and I luckily had this skill set. And at first, I understood what problems were in front of me and then how to address those when I was taking care of a potential organ donor and working with their family. And then I began to realize that if the whole system isn't lined up the right way to accomplish that work, a single provider cannot make a difference, and other people would hit similar barriers. And so I wound up realizing that there was this unmet need, which is awareness around organ donation amongst donor hospitals in the country. If you're a transplant center, you're going to think about organ donation because your transplant recipients need those organs. If you've never taken care of a transplant recipient or someone on dialysis, it might not occur to you that organ donation is relevant for them. But every hospital does have patients who might become brain dead or might be able to donate organs after circulatory determination of death if their family decides to withdraw life support because they have a non-survivable injury or brain insult. Then every hospital has an incentive to work on end-of-life care and preserve that option of donation. So in our country, over half of adults are already registered on state donor registries on their driver's license. And when we ask families when that hasn't happened, over 75% of families say yes when organ donation is offered to them in the right setting. And so that's a pretty big endorsement. Most of our patients and families would choose this if it was made available to them. We also learned that families whose loved ones pass away after organ donation have better grieving and depression scores 6 months later than someone whose loved one passed away and did not have organ donation as part of that process, which makes sense. You've got something positive to also think about as the legacy of that loved one. And so you've got all the hospitals in the country that have patients who might experience that in their families, a small number that take care of transplant patients, and you've got organ procurement organizations and transplant programs that work in between and take care of patients across the country in different hospitals. And so not preserving the option of organ donation was something that lots of hospitals were exhibiting. And so you'd have patients who might become organ donors, but they couldn't because people didn't pay attention to their critical care needs. And so I found myself in the middle of this confluence of donor hospitals, transplant programs, organ procurement organizations, and the overseeing regulatory bodies. And I was a trauma surgeon who was really interested and willing to lean into that space. There wasn't a lot of interest in the trauma community or critical care community in advancing this at scale. And so I wound up recognizing that there are these great stories. There's great ways to motivate people if they hear the stories. And there's some process measures that people couldn't put in place to improve outcomes. And connecting those dots is something I found myself sort of uniquely in the middle of and able to affect change around. And that's where I got started sort of translating data and stories into common goals across disparate groups to align towards a common goal and affect change at scale. And I think that type of skill set was both something I'm really passionate about and still am involved in. And I've been able to use those skills and that philosophy to tackle other challenges in healthcare.
Yeah, that it's interesting sometimes how you have those experiences and they weren't necessarily planned. Sometimes you just fall into them, but when it aligns with your interest, and particularly when you're talking about how you were able to use data and information and use that to really drive behavior. Maybe we could double click on that a little bit. I'd love to hear some of the stories of what did you actually do that motivated and how did you bring about those changes?
Certainly. So the first story I heard that really got me hooked even thinking about it, you can maybe even tell my voice just changed. I'll get a little sort of choked up even in thinking about the story. And so I'll share the story and then tell sort of how we used it. So I was at an event where the organ procurement organization in Los Angeles, One Legacy, was engaging local hospital staff, lots of critical care nurses, ER nurses, sometimes physicians, and administrators. And they try to connect to purpose by telling an organ donation story. And a lot of times, at first, the government would talk about how we have people dying on the waiting list who need transplantable organs. And that story, as I mentioned, doesn't resonate with everybody. It resonates with a lot, but not everybody. But the focus of thinking about the donor family, so a loved one who passed away and how that helped that person move forward and connect those dots is really what's meaningful for me. So I heard a mother come speak at a conference for hospital staff. And she described how her 7-year-old son went to elementary school. He was always the most generous kid. And she would comment on how he'd often come back from school with like his pencil case without an eraser or without a pencil. And she'd say, what happened to your school supplies? And, oh, well, one of my classmates didn't have one and he really needed it. So I let him use my eraser today and he didn't get it back. And so she tells the story of how her son was very generous. So he winds up, unfortunately, having a spontaneous intracerebral hemorrhage. And that happens in school. He's taken to the hospital. His family and his mom are informed that he has become brain dead. He has passed away. And the natural process then is once that is understood and people have started sort of understanding and grieving, the option of organ donation is brought up to that family. And when this mother and her husband were approached with this possibility, they thought of their son's generosity and how it's something he would probably want to do because he'd probably give his organ to a child because he was so small and young. And so she agreed, and they agreed for him to be an organ donor. So then she fast forwards to about a year after her son had passed away. And if an organ donor family is interested and the recipient or their family are interested in meeting, they both can connect through the organ procurement organization. And if both sides agree after 6 months, they let them meet and work through that. And this mother described how she was invited to the recipient of her son's heart to his birthday party. And every year she gets invited to his birthday party. And she gets to see her son's heart grow up in someone else's body. And whenever the boy who received the heart sees her, he says, "Thank you for my heart, mommy." And so you realize that it obviously transformed the boy's life who got the heart. And it's given this mother this legacy of her son's life. And that's definitely changed the way that she experienced that grief. And so being able to help facilitate that to me is very meaningful. And it's hard to tell that story and not get a lot of tears. So then you shift to, well, what can we do to make that happen? And then you talk about how the percentage of patients who've already signed up on registries is high. And in Oregon, it's over 75%. And then how other loved ones say yes when they're asked appropriately. Then you realize this is what people want. They want to become organ donors. When their loved ones donate organs, they have a better experience. The lives that are saved are obviously impactful, and they obviously help our system. And so then you break down, well, how do you do that? Well, in your hospital, there's some data that shows that you have patients that have their families are saying no when they're asked more commonly. And we notice that people on your teams are mentioning it too early. Or you're not doing enough critical care to maintain the organs when the family says, yes, we can't even use the organs. But the loved ones wanted it to happen. They wanted to maximize that gift. So then you've got data from the organ procurement organization you can bring to bear that shows areas for improvement. You've hopefully got them hooked on the desire to improve and how what's in it for them and their families. And then you try to move forward with some common solutions and then track the data over time to show improvement.
What a touching story. And it's so interesting how the impact of stories and the ability then to use stories like that. And the thing that I find particularly interesting is how the story, it's not just the benefit to the recipient, but the benefit to the donor. It's that whole notion of what's in it for me. And by, that notion of, hey, by being generous, it helps you and it helps everyone. It makes the world a better place. But it makes you better. Those are important stories to share. Let's kind of transition, and that's a tough thing to transition and pivot from, because it's so meaningful and so personal, and I can see where you have a lot of passion around that. Um, how do you move from literally saving people's lives and making this difference also in, where people are in very unfortunate situations, putting them in a better spot, to let's do something on a more broader scale in performance or value care delivery?
Yeah, thank you. So I think the skills and maybe the patterns of behavior that were relevant in that organ donation space that I use today as Chief Clinical Transformation Officer at OHSU, and have evolved over time in between, there's about 15 years of work in between those things, is really that notion of uh, having a story around an unmet need, and then leveraging data to make it real for everyone involved. And I think that became very true with value-based care and clinical transformation. And the quintuple aim really does address a lot of the elements that we've been talking about, but haven't really said it out loud. So in that organ donation space, we talked about how there are recipients who need organs, so they benefit. That's the clinical outcome space. You have total cost of care. That gets improved with transplantation versus dialysis, let's say, or organ failure over time. Then you have equity, which is very much baked into the transplantation allocation process and appropriately trying to find organs for all populations. And there is still room to improve in that space, though, in the transplant world. We're still learning to do better. You also have care team wellness, and you have experience. So in turn, on the experience side, we talked about how a donor family mother will experience end-of-life care better. That's better experience for them. And then you've got the staff. So when you're involved in work that improves lives, or just even improves outcomes, we all get a little dopamine surge from seeing an improved metric. A lot of even self-help or personal health things we get better in when we're able to tie into something that shows us what we're doing. It's gamification of sorts. And so the quintuple aim really tackles a lot of these elements. And in organ donation, we also added an element of donor family celebrations. And the point of that wasn't actually just to honor the donor families and the donors who passed away, but it was a chance for the staff to come and see those families be honored. Because then the staff realized they helped make that happen. And so they're getting wellness out of what they did. And so when it comes to value-based care and the quintuple aim, you have all those same elements in play. And so one program that I was able to work on that I think tied a lot of these together was CMS's bundled payment program. And that was BPCIA. OHSU had previously been a part of the Comprehensive Joint Replacement Program, CJR. And that was led with our orthopedic surgery department, our rehab teams, some administrative teams. And they went to a boot camp sponsored by CMS on how to do this for orthopedic surgery patients. And they did a great job. They learned a lot of lessons. They eventually got to a decreased total cost of care. And that was based on there being a really committed surgeon on the team who understood and bought in and was able to do the training and come back, tell that story, and be passionate about it. Katie Schabel is her name, orthopedic surgeon, has done a great job with that program and still a medical director for episodes of care. That program was ortho-specific. The orthopedic community was embracing value-based care. They're one of the first groups that CMS, I think, wanted to regulate because CMS worries about cost of care, quality of life. They worry about longevity as well. They have patients for a long term as an insurer, where a lot of other insurance companies don't when patients change plans, change jobs. And joint replacements are commonly done. There's a lot of variation in outcomes and cost. So they wanted to standardize that as best as possible, get better results, and get better value. So the orthopedic community saw this as some mandatory programs. They started embracing it and became some of our early adopters in the specialty world of value-based care and some population health principles that a lot of our primary care colleagues were already learning and trying to do at scale for a long time. And so then the program came as BPCIA, which was voluntary, but the writing on the wall was these would become mandatory programs, as I mentioned earlier. So OHSU leaned in and said, we want to become more experienced in the space, go beyond orthopedics, and try to take those skills and apply them to other surgical and non-surgical populations and try to be effective in the space when there's less risk, it's voluntary, we can learn, become competent for when it's mandatory, and it'll teach us some of the skills needed to take on maybe an ACO or a Medicaid delivery system or an IDS, integrated delivery system, which was what we call it here in Portland. And so I was doing my medical director role working on e-consults, which is my first foray into value-based care and digital health at OHSU. And I helped interview somebody who was going to be a project manager for the bundle payment program. He was also an outside-the-box thinker. He came from health information management. He wound up teaching change management as part of our business program here. So he was someone who was willing to take on that challenge. And after he was selected and he came to some of our team meetings and heard how it was going, I saw that he wasn't making any headway with the clinical leaders and the clinicians. The administrators may have understood there's a program coming, but how do we get care to change and get clinicians to buy in? And so we began talking about what creates value in the program. What CMS cares about is not how much you spend in the hospital, but what you spend what those patients consume, what Medicare spends 90 days after discharge. That means if you go to a skilled nursing facility instead of home, that's going to cost more. If you're in that facility longer versus shorter, because you don't get rehab as frequently, that's going to cost more. If it gets discharged home early from the hospital because we're trying to create capacity on our side, or the team's trying to get their list to shrink because they got so many patients to take care of, and that's a natural goal, is to get people discharged, but they aren't prepared for discharge, they're going to bounce back, wind up in the ER, that costs more, get readmitted with a complication, that might cost more. Or if you just get complications with your normal care, you might wind up with more readmissions, and that's going to cost more. So the government loses on that, our health system loses on that, and the providers were like, so what? I'm not losing on that. The hospital makes plenty of money. I don't need to worry about that. So then you bring it back to the patient. Well, your patient didn't want that to happen either. And you realize that the metrics we're tracking are post-acute care spending. And as we're telling the story to clinicians, we're getting buy-in from some who might understand the systemness, might understand the quintuple aim. Maybe they've had some business classes. They've heard about value-based care. And this was in the 20-teens, so there wasn't as much adoption. And we began realizing that that's not resonating with a lot of our providers, especially when we got to the medicine teams that take care of hospitalized patients with unplanned admissions. These aren't surgical admissions for joint replacement or spine surgery. These are CHF, urinary tract infection, pneumonia, not planned. Don't get to talk to them in advance about their stay and what's going to happen afterwards. Unplanned admission with patients with chronic needs, often a lot of needs for social services as well, let's say. And so to connect with those providers, we began thinking about our data. And if you looked at what made a patient wind up under their target price that the government set for us, it was less time in the ER, less time in a nursing facility, and not getting readmitted to the hospital. Those were the big spenders. So how do you align efforts to try to decrease those? Well, the providers weren't feeling it as much as some of the other administrative team members. And so we said, well, in a parallel a project I had done around caring wisely, around setting goals of care for patients and providing care that they want to receive, not just think that's next if it's not going to help them have a good quality of life. We learned that 70% of patients when surveyed would prefer to die at home, which is getting to a far extreme end of the healthcare spectrum, but only 30% do. 70% actually die in a hospital or a facility, which is not where they want to be. And you extend out that knowledge and people want to get lots of care at home. They want to be at home. People like to be at home a lot more than they like to be in a hospital or a healthcare facility. And home could also be at work if that's what you're spending your day doing. You're just not in a healthcare facility. And so we realized that the inverse of being in a healthcare facility, which costs more money in those 90 days post-discharge, is being at home. So we changed our metric to days at home out of 90. So after discharge, if you were at home for 83 or more days out of 90, so less than a week in some healthcare facility during that time, you were going to be under target price. So our goal then became not getting under target price, but it was having 83 days or more at home out of 90. And we tracked that in parallel with our costs, with the data we got back from CMS, to then have a holistic measure that was obviously patient-centric, cost-centric. In order to get people home, you have to have an equity lens to bring services to those environments. You have to address care differently to have different populations be able to stay at home. And the care teams felt better about it as well. The care team wellness improved. And it's a win-win situation. When you find those sweet spots, I find it's really gratifying to work in that space. It's obviously gratifying to get results, but to connect those dots and have the care provider say, yeah, I can get in line with that. I can try to help someone be at home more. So how do we do that now? I see the end game. What steps can I take to make sure that patients can be at home more when they're discharged? And then you get people on board for solving the problem.
Now that's a great story, and it's great also how you had data, and I'd love to hear more about that, where you've got all this information, the data is not working, and then you come up with something that does work. Tell me a little bit more about that process when it wasn't working. How were you feeling? And then how did you go from, okay, we're tracking this data and information, not getting a result, to this is the one? And then how long did it take before actually it's like, oh, this works?
Sure. I said the time we noticed we had a challenge was in terms of how we approached trying to do better in the program. Was we still had to take probably a good 6 months to learn the data, see it come in, see where the moving parts were, where the opportunities were, and that's getting your claims data back from CMS. We also tried to recreate that internally, which was a challenge, but we did a pretty good job of being able to preempt and know how we would do, because you had to decide to stay in the program each year before you kind of knew how you were doing. So to take on risk, we wanted to have some leading indicators of how we would do. And the way we were going to try to learn where the opportunities were was to look at patients that were over target price and then do chart reviews. And we started with our medical directors, which at first was me, and then was able to recruit others to join the team as we had some success and some scale. And we start with chart reviews. And we can do the chart reviews for the medical director of that specialty, but then they're not as engaged in seeing the problems and fixing the problems. And we start by saying, we'll do the first few, we'll show you how we did them, and then we'll show you what the results were. And some specialties would engage in the chart reviews. Some would take it on after we showed them and do it and come back with their findings. They were engaged. That was great. But there were some specialties that just weren't taking the bait. They weren't engaging in chart reviews. Oh, I didn't get around to it. Can you do it this time? Or what did you learn? Okay, that makes sense. And when that happens, you're not getting clinician engagement. You're not going to solve the problem, because nothing's going to actually change in the operational sense. The clinic manager can get on board. The post-acute care team can find a better SNF. We can get PT to come every day. But if the clinicians don't talk to patients about it and don't lead that initiative, we're not going to get the same buy-in and the same results. And honestly, it wasn't a prescriptive process. It was, we're getting data, we're analyzing it, we're seeing patterns. And I think something I mentioned earlier was I did a lot of research with the organization, data and improvement work that we did. A lot of that research turned into publications, turned into grants, and turned into some impactful articles and some randomized controlled trials. And the reason I mention that is, one, I think it gives a clinician leader credibility with other clinician scientists if they have that sort of imprimatur of, I've published in this journal, or I've done this kind of research. And if people know that about you, they know that the sort of integrity and the knowledge you have around data is legitimate, that when you bring data to bear, that's also seeing that they're seeing something you've done in their world that they can connect to. And so being able to tell a story and look at data and find patterns and trends and opportunities is something I think research helped me with. And so looking at the data with lots of colleagues, this isn't work I'm doing by myself by any stretch. This is very much takes a village. So we have great analytics team, project managers, informatics team members. So people really are brought to bear to really pull this off. And it was just seeing a trend in the data, seeing clinicians say out loud, why does it matter to us to make more money for the hospital? At that time in healthcare, there were people not getting raises they wanted, which has been a challenge for a while. They see budget cuts happening in certain places, and they're not really feeling it. They're not saying, what's in this for me, as you said earlier. And when we found a way to make the measure patient-centric, and patient-centeredness had a lot of traction at that time. And so when we tie it to that, we recognize there's data that shows what patients want. People hear it from their patients. We start connecting those dots. Then we see them engaging in chart reviews and talking about readmission prevention, because that's where the biggest probably bang for the buck is. And what would it take to prevent readmissions on our patients? And that's where we move to as our single entity of intervention, to keep it simple. And we connected around days at home, because that's, if you're readmitted, you're not at home as much. And then we were able to see the clinician engagement by their willingness to engage in chart reviews, basically.
That's fascinating. This whole notion of change management. How do you bring about that change management? It's, as much as there's a science to it, a lot of it is an art, and there's this human factor to it of really the right people, getting the right people engaged, having them become passionate about it, sharing that shared goal. Otherwise, it just doesn't go anywhere.
Definitely.
So another program, let's kind of keep on this thematic of some of the different programs. One that I think is a fantastic program, Hospital at Home. I know that you guys are engaged in it. It's always interesting to me that, typically when you look at some of these programs, that there's not payment, or it's a grant-based payment, so it's difficult really to get momentum. Hospital at Home has been kind of a little bit of a head scratcher for me, because you got payment in place. I know there was some uncertainty around the payment, but now I think it's been fairly well solidified. Patients benefit to patients, benefit to the health system. So, it truly is that proverbial win-win-win. Yet it just seems it's really hard to make it happen. So I'd love to hear about your experience and what you've observed and how you've been able to tackle that one.
Certainly. So OHSU has had kind of full circle journey with Hospital at Home, but it began in the pandemic. And I will admit, before the pandemic, I was doing some consulting for a healthcare startup in Portland, learning about patient experience, consumerism, digital health in the early phases in the 2010s. And I worked with a colleague there who was a cardiologist who had left his clinical practice to work full time for the startup, who was trying to take everyday care and then add specialty care on board. He was trying to add a cardiology lens and add other specialties. So he was all in and thinking about new models of care delivery. And he mentioned Hospital at Home to me. And I will admit, my first reaction was, no one's going to think that's safe. No one's going to think that's okay. We're thinking about doing ambulatory surgery at the time and taking patients off the inpatient only list and doing them in ambulatory surgery centers. And that was a leap of quality and safety for many people, including myself. And the idea of providing full hospital care at home. I saw a limit. I wasn't curious. It wasn't my initiative. I didn't pursue it. And I think that mindset shift around complexity for me began by thinking about all the digital health we had launched during the pandemic. So in the first 3 months, we had to scale video visits really quickly to maintain access. We had a vision to accelerate over 5 years, but the pandemic really was a catalyst for it, which was great. And I remember sitting in one of our briefings for our health system and had just talked about how we had massively expanded video visits. And at first, people thought that wouldn't be safe, that you had to be seen in person to really feel, do an exam on a patient, interact with them, to be able to do care safely. We didn't have that choice to go as slow as you maybe wanted with advancing virtual visits, maybe one specialty or condition at a time. We had to do it massively at scale. And we learned that it could be done safely. Patients could handle the tech. We could handle the tech. You could take care of patients well and refer them to come in when you needed to. And once we had vaccines, we were able to see more people, and that became easier. But that was what started my imagination change. Was we saw video visits scale quickly and safely. We tracked outcomes. And it wasn't as good as in-person care for some things, as we had to learn which patients should be seen in person, because we learned what got missed. Like you didn't see the leg swelling because the camera was up here. Okay, CHF, we might need to look at their feet or have them come in, something like that. And as we were presenting our massive scaling of digital visits in the ambulatory space is when our hospital leader was talking about our plans for opening a new tower. And I said to him, hey, if we can do all this clinic work with video, do we need more bricks and mortar clinics? I know we're building a new tower, but maybe we don't need as many ambulatory centers, which we also think we need. Maybe we can do more digitally and not need brick and mortar clinics. And maybe we don't need it as much for some of our hospitalized patients. And the first reaction was almost like, it was a snicker. It was like, oh, right. Well, let's stick with video for ambulatory right now. But my first reaction I got back from leadership was, that's too outside the box. That's too many steps forward. So then 3 months passed. Now we're canceling surgeries, and I brought it up again. And now there's more receptivity from the same hospital leaders. And so that was what got us administrative buy-in to then explore adopting this model. And we engaged with some teams to explore how to do it. And then it became, okay, this can make sense financially. we're looking at the contribution margin of if we can have a patient that's lower acuity be taken care of at home. Looks like it's for pneumonia and they're oxygenating well enough and they can go home with a pulse ox and not too much oxygen and give them IV antibiotics. RT and nursing can come to the home and that works. And we can fill that bed with a transfer who needs surgery. Now the hospital's taking care of a more complex patient. It's helping the bottom line. And that offset on different reimbursement for those two admissions was a way for us to make sense of this program. Because it's going to be a cost center, but you're going to get higher acuity patients in the hospital. And that's how we made sense of the program. So that worked financially. And then the challenge became the buy-in from the clinicians again and the patients. How do you convince patients it's safe? We know they want to be at home, but they still might not believe it's safe. And then that's where using data, demonstration projects on the East Coast had shown success, that patients are readmitted less frequently, they're more mobile, they sleep better, they like the food better. So we were able to benefit from the experience of others who had gone first. So kudos to them for doing it and sharing their experience. So that made sense to patients. It made sense to some of our clinicians, but we still didn't have a lot of trust because you get someone who needs to be admitted, then you talk to the hospitalist, can this patient get their care at home? And they'd say, a lot of the times the answer was no, partly because they hadn't thought of it before, partly because it was more clicks and administrative work to then just do the admission I know how to do, and I've done it 100 times in the last month. And so then we had to think of ways to build that buy-in. And so using some design principles, we built a vignette or worked with a firm that had a mobile hospital at home type setting that patients could come sit in and experience. Care team members could come look at and see what it's like with the technology and the connections you get in the home and hear some testimonies from people who had done it. And so we eventually worked on culture change. And then actually my mom became one of our first hospital at home patients. So I was drinking the Kool-Aid. I knew she'd benefit from getting IV steroids and getting her labs checked at home versus being in the hospital for just those purposes for a hepatitis she'd had from a drug toxicity. And so she had great success. I can then talk about it more intelligently. I went for the check-in when the paramedic came to the house to start the whole program. I could talk about it better, which then helped me talk about the program. And so it really became another form of change management and culture change by sharing the why, telling stories about the benefits and people experiencing it well. And then over time, with the right investments and having someone assigned to triage patients to hospital at home from the hospital medicine team was one of our eventual triggers, because then you had an engaged clinician on that team whose job it was to do this, who then had that credibility amongst their peers to advance this work. So sometimes it's about relationships as well and leveraging those when you need to affect change.
That's fantastic. I love the personal element that you threw in there as well. It's always interesting when you're thinking about something conceptually, when it really becomes more personal. Oh, what would you do if it was your mother? I think most clinicians would say, if you can be home, you're better off at home. And so that's fantastic. Appreciate you sharing that journey. So we're a couple other things to cover in our time. Let's be a little bit more present day. So let's think about, for some of the programs you're working on today, what's the one? So pick one of a current program that we don't necessarily have results yet, or maybe have early results that you're excited about. That you're like, this is really where I've got a good dopamine hit.
Yeah. So this is probably a career highlight for me. And it hasn't come to fruition yet, but it was the confluence of really so many aspects of my career coming together into one place to hopefully to make a difference and amazing people to work with along the way to really accomplish it. So our Office of Digital Health was created through that strategic planning work back in 2019, I mentioned, because we wanted some systemness around deploying tools across 3 campuses. And we used a lot of our change management, culture change, telling the why. We use a lot of those skills to gain digital health adoption. We also began thinking about who wasn't on our team and what skills could we use to really drive digital health adoption. And we wound up being introduced to someone with human-centered design expertise. His name's kind of cool and impressive, so I'll mention it, Hans van der Schaaf. And he had a PhD in human-centered design, or really technology adoption. And he had gotten his PhD at Portland State University, and part of his thesis was developing an app for students at Portland State. and having them do a lot of self-service for them, which obviously you can see some parallels to healthcare with my chart, right? So if the app works well, students have better connection to their information, their classes, pay their bills, you need less administrative overhead, less phone calls, less frustration. So it's a win for the whole system, but you need people to use it. So his expertise was on technology adoption using human-centered design principles. And what's unique about that I've learned and really sort of embraced and become someone who likes to embody this and try to promulgate it, is the idea that what often gets in the way of change are social and emotional barriers to driving either technology adoption or other process changes. And if you use human-centered design, it's really empathy-based, with empathy-based interviews, current state assessments, observations, journey maps that really assess different people's experience in the same situation, and what are the high points or the low points, and what are probably the barriers to affecting change. So you're trying to find out what would be the best thing to change because it's the biggest pain point. And then also, what are the feelings that might get in the way of embracing some change and a new path forward from, let's say, the care team members or even the patients. And so we realized that we wanted to expand our skill set. So we hired Hans and another experienced designer followed. And we began using human-centered design as part of how we drove to the design of our tools and then the adoption of our tools. And one thing that was useful for was digital navigation, how to help patients. This was directly translatable from his work with app adoption for students. How do we get patients to learn how to do a video visit when they're saying they can't, and they just use a phone call instead for a phone visit? So we use human-centered design, interviewing different populations to really work in that space to derive a digital navigation program that meets people where they're at in a way that they want to receive help, convert those into video visit users instead of phone visit users. So that was done in the past. And with that skill set in mind, and the fact that we've had a lot of digital health adoption at OHSU, our office's focus changed from using our human-centered design and change management, culture change skills to drive digital health adoption to just solving sticky problems for our health system. And we became the Office of Care Transformation and Innovation. And one of the first projects we were asked to work on was the notion of transferring patients from our ER, where lots of patients were boarding for days on end, and sometimes never even getting a hospital bed upstairs, quote unquote, and getting their full hospital admission in the ER. We needed to address that challenge. And it also came down to capacity and finance as a challenge for our system, and really bad outcomes for patients. Receiving your entire care in a hallway versus a private room, your sleep's disturbed, your privacy is obviously affected. And when people are taking care of you in a non-typical environment, the care probably is going to be affected. We know that we do better when we're doing things in a normal way, in a routine way, in a routine environment where we're comfortable and familiar. So there's lots of room to improve. And the staff were experiencing burnout and moral distress because of it. So massive challenge. We have a partner facility in our system that needs more patients to be in their hospital, community hospital, lower acuity of care, and they need more beds filled. We've got people in our ER that we can't put into our hospital. So how do we help those patients see the wisdom and value in agreeing to be moved to one of our partner facilities? They need to consent to that. They need to agree to that. And what we're finding is one of my friends I had trained with in medical school is actually a surgeon here at OHSU, and he's a health system leader also. And he was relaying to me in just one of our chats that he was hearing as a new vice president being exposed to some of our budget challenges. He goes, we really need patients to transfer to our partner facility. They need the patients to go there. We need the capacity, and the patients need better care. And he shared a story of how he had someone who was a donor to our hospital, highly involved. The physician, husband was a physician in this family, and he's the one who was ill. And this woman had reached out to people she knew to try to get him a bed. Figured with all my connections, I could try to get him a bed in this facility. I go, we don't have a bed for your loved one with this condition right now. I'm really sorry. But this vice president goes down to the ER in the hallway, sits there with the patient and his spouse, and says, we have a bed at our partner facility that he can go to in a couple hours. He'd sleep, he'll get his pain controlled, we'll take care of him adequately. And they wanted to stay for 2 more days in that hallway and went home from there. Never got admitted. So it wasn't logical, right? They were saying no for a non-logical reason. It makes lots of sense for them to say yes, but they were saying no. Why is that? So it made me think about my work in organ donation and transplantation again, where when CMS decided to make it a priority and focus on organ donation, they were finding that lots of families were saying no when they were asked by the hospital staff. when the doctors were asking patients if they want, and their loved ones, patients for brain deaths, they weren't asking them. They were notifying their loved ones that they had passed away, and they then asking them about organ donation. Families were saying no way more than half the time. And the government learned, that our healthcare teams weren't trained to have that conversation with the right type of empathy and sort of trauma-informed approach. Basically, someone just learned their loved one died, and now you're asking them to give something. And so CMS has requirements. You have to have a trained requester approach all families. The hospital teams aren't supposed to do that. They can notify you that your loved one has been declared dead by neurologic criteria, and that someone will come talk to you about the next steps is the best approach. And then you might introduce this organ procurement family support person who's going to come have this conversation, who's been trained to do it. You might also train someone in your hospital to do it. That's also possible. They need to be officially trained, because when you're trained the right way, you'll get more yeses, because you're more informed in how you do that. So I had that experience from organ donation and transplantation. I thought about human-centered design. What's getting in the way of this logical decision being made? It's a social emotional barrier. And so I said, how about our team works with you guys? Let's partner with patient experience. So we had patient experience on this for a year. We had marketing working on it. Marketing's trying to highlight the benefits and quality of care at our partner hospital. We're finding that patients who live closer to it are more likely to say yes because they know the name. Or if you've received care there before, you'll say yes. So we thought about maybe we can just raise the reputation of this hospital and give you a flyer before we ask you. It tells you how good the hospital is, and then you'll say yes. That's also logical. It's not emotional. And so I heard all these steps that have been taken, and with all of these efforts for a long time, the consent rate was at best 40 to 50% when the ER docs were asking the families and the patients if they would change locations, and they're staying in a location that wasn't as good for them. So we partnered with patient experience, marketing, our ER teams, and we wound up interviewing staff in all of these walks of life who are all involved in this transfer process, case management, our trauma, our transfer nurses as well. And we interviewed families who said yes to transfer and patients' families who said no to transfer. We asked them about their experience. And the reason this was so gratifying was we're connecting all these dots on different areas of work that many of us have done in the past to address a simple question. More patients saying yes to transfer to another facility when it's in their best interest and our best interest, with huge financial implications and quality of care implications, and we can't get past it. Sticky problem needs a solution, and it's an emotional solution. It's not a tactical or logical one. And so we came up with an approach with more messaging around what patients needed. It was they felt like they were being pushed out. They felt like they didn't feel confident in the next destination. They maybe hadn't received care there before, which I mentioned earlier as well. And so they wanted an endorsement from someone on the care team. Turns out our ER department at OHSU staffs the ER, the other hospital. They're all the same faculty. The hospitalists are often also work for OHSU. So the doctors, we can say, are the same. They often work in both places. They often trained at OHSU and work there. So that was an easy, my partner works there. They're great. They're even working today. I know who's on today, who you would probably see. That helped. But what was more helpful was we learned that the physicians didn't have the time or space to have an appropriately emotionally informed conversation with the patient and family. They need to sit there for 10 or 15 minutes and be in the right emotional setting to do that, and to have a compassionate and companionship approach. Be with them on this journey. Explain that we've got a bed for you. The best location for you, or we can send you, is this partner hospital. We've worked with physicians there as well, and someone's going to come talk to you about what that looks like and what questions or concerns you might have. So what's also for circle here is the nurse who was able to do this was a former hospital at home nurse at OHSU. So she had talked to patients about being in alternate forms to get their care. Before they left the ER to get hospital at home, she was talking to them about that transition. So she had a very unique perspective on how to attend to that vulnerability that patients had about getting care in a place they hadn't considered before, which is what's happening now. It's just still a physical building. And so she would sit with them. We had some scripting. She would just have a great approach, and she would sit with them and ask them these questions. And she had a 78% consent rate in 1 month. So 48, 45% up to 78%, almost doubling, which has massive implications. We had a record number of transfers that month. It helped ED throughput. It helped the quality of care. It helped the bottom line. And so with that learning launch of a low-tech solution, actually no-tech solution, we changed the approach, got different results, and then got buy-in to have the ED case managers take on this role and have it be a full-time thing that someone does all the time. And now we're in the challenge of implementing that with people that weren't part of the design process. They don't have that unique experience of a hospital home nurse who has that unique perspective. And so now we have the challenges of modifying it, getting it adopted at scale, which is often the secret sauce that's hard to miss or hard to get right sometimes. But finding that initial result by connecting all these dots with the new approach was really gratifying. Even connecting a lot of my prior experience in organ donation and transplantation made that even more gratifying. And now we still had huge, the massive success at scale yet, because we need to scale it and have it happen routinely month over month. And so we're now with that challenge, but it's a fun challenge to have.
Darren, what a great program and initiative to be working on, and really something that's almost a little bit of a capstone here of tying together everything that you've been working on. And I love how it's still in process, because it gives us an opportunity perhaps to talk again in the future and see where you're able to scale it and how you got the teams engaged. Really appreciate our conversation, Dave. Man, we covered a lot, and you really have this unique skill set and passion. Want to give you a chance to kind of to give our viewers, what is your key take-home message? I know we talked about data, the why, and the stories, but would love for you to kind of put it in your own words. If you want to say, here's the thing I want you to remember that I think is going to serve our communities the best, what do you want to share?
Yeah, if you had asked me this question 5-10 years ago, I'd probably have a different answer. And if you asked me when I was an early physician, it would have probably been really about science or medicine. But at this point in my career, I think it really comes down to human factors and human emotion. And so I would say, if you're experiencing a sticky problem and you can't figure out why you can't get past it, I would go to the gemba, so to speak, but not just observe processes. Interview people and ask them how they're feeling when they're doing the work, and find out what makes them feel better and what makes them feel worse and what gets in the way of them adopting change. And you'll probably wind up getting better results in the future. Figure out what drives people and what gets in their way, and find a way to relieve those problems and connect to what makes them feel better.
Well, Darren, I got to tell you, I'm feeling excited and grateful that we had a chance to have this conversation. And I love that encapsulation of focusing in on the feelings element of it, because I think that really does get at the heart of it. And really appreciate all that you've shared with us, all that you're doing, and excited to see what's going to come for the future. And so perhaps we'll be able to get a chance again to chat at some point and see how some of these things are unfolding. So thank you so much for joining us. Thank you for your generosity of spirit and time, and really appreciate this. So for our viewers, our podcasts are available on YouTube, Apple, Spotify, and pretty much any of the platforms you want. And so whether you want to listen or you want to watch us, depending on the mood that you're in, hopefully we'll see you again soon. Thank you so much for joining.